Ah. Hi everyone, I'm Samuel Wasserman. I'm the research coordinator for the Department of Pediatric Anesthesia. Thank you all for having me here today and to present my project on the Trans-Canadian Esophageal Atresia Registry. This project has been a very long and interesting process in putting it together, so I'm happy to finally be presenting some data on it. So just some agenda items for today. I'm going to go over a bit on the history of the database, the current status of the registry, our preliminary findings, issues we have with the database, and how we want to proceed in the future. Firstly, I'd like to acknowledge.
Okay. Just tell us who you are now.
So first off, I want to acknowledge Dr. Levike and Christopher Fuer. Those were the two individuals who started the registry. I'd also like to thank Helen Basha, the clinic nurse, and the rest of the team members, as well as the pediatric surgeons for their help in collecting this data. I'd also like to thank Dr. Laberge, who has been keeping this registry alive. Without him, I wouldn't be here presenting. So this registry started in about 2006. It started around the time in which the Esophageal Atresia clinic was built at the MCH. And when this registry started, it was all the data was being collected on paper case report forms. However, in the summer of 2022, close to the time I started, I was approached by Matthias to design a REDCap database so we could input all the data into REDCap. In the fall of 2022, we entered in all the data. I had some help from medical students and one of the lab students, Zainab. So thank you for your help. In the spring of 2023, we analyzed the data, and in the winter of 2024, we submitted a short communication and are awaiting acceptance from the Brazilian Journal of Anesthesiology. So this registry, it has around 4 questionnaires. It uses 4 questionnaires. So we collect the initial history of the patient, and then we collect the evolution of the assessments, complications, and treatments used at each clinic visit. These forms were taken and we created REDCap instruments. And these are all the patients that have been entered in. Yeah, so it has the instruments and then it repeats each follow-up visit because these patients are seen multiple times. So for the paper that we put together, we were primarily interested in whether there were any gastrointestinal and respiratory complications during the first 60 months of life in children born preterm. And then we also wanted to look at treatments required during the first 60 months of life in children born preterm. Secondary to this, I also wanted to look at the minimal sample size required to predict these complications. I ended up deciding to just look at the power for the sample size instead of calculating what the required sample size was. So initially when we put together the study, we wanted to run a multivariate logistic regression. I said no, and we ended up doing chi-squared because we did not have enough data. So in this database, we have 142 patients born with esophageal atresia. Gestational age was recorded in 44 of these patients. 14 of them were born preterm, and 29 of them were born full term. In the preterm patients, we showed that there was a greater need for gavage feeding and stenosis, and there was also a higher incidence of stenosis. And interestingly, we also saw that they were receiving less anti-H2. We noticed no differences in respiratory complications between the two groups. And in terms of the sample size, when I powered the data, we showed that the ability to correctly predict a complication treatment correctly was associated with a power of 50%. So our power, pretty low. When we started entering the data into the database, we saw a number of problems with the data being collected. Number one, we saw that the year of patient had the assessment wasn't necessarily put down, so we didn't know if it was being done during that follow-up period or if it was done during a different follow-up period. Next thing we noticed was for the visits during the 60-month period, some patients would only have one visit and some patients would only have two visits. So when we were looking at medication, particular anti-H2, we saw that the preterm patients had received less anti-H2. This was probably because these patients had few visits and they were later on when they were older, when they weren't taking this medication anymore. So it ended up looking like they received no anti-H2 during the 60-month period. We also had some ambiguities. So as you can tell, if the patient required steroids, you can see that it says no, and then they did receive them. So I'm not really sure what to put there into the database. We also had a lot of changes in the database over time. So this database, as I said, it was started in 2006. The case report forms have changed over time, and some of the outcome measures were different, and where the data was also changed. So just to recap, some of our limitations. There was a high volume of missing data. There was poor data quality. I was having to interpret handwritten notes and translate notes from French to English. We also had a small sample size, giving us low statistical power. And we also noticed when we looked at other studies to try and increase our sample size, we couldn't compare our work with other registries. Other limitations to note are we weren't able to really discuss the effects esophageal atresia had on quality of life, and we didn't have many subjective assessments, so we couldn't capture the complex nature of esophageal atresia. So moving forward, this current registry that we have, it isn't viable at this point. Our hope now is that we can build a trans-Canadian esophageal atresia registry to hopefully improve the amount of data that we can collect. This new registry, it would involve multiple specialties. So we would involve anesthesia, surgery, ENT, respirology, gastroenterology, and NICU. And the hope is that with this registry, we could improve data capture and increase our sample sizes. Lastly, our hope with this registry is that we could improve care and standardize practice. So I just included a survey on the management of esophageal atresia and how often physicians have visits with their patient. And in patients less than a year old, it was about 2% of physicians had standardized visits. And we know that within the first year, 34% of patients have some kind of medical complication. 59% of patients have new hospitalizations, and at 12 months, 15% are undernourished, 37% have respiratory symptoms, and 15% have dysphagia. Also, if you continue looking with the older years, it's still highly variable on the number of physicians planning visits with their patients. So, with the Trans-Canadian database that we're working on, we've acquired the REDCap database to work on it, and we've had our first meeting with the Trans-Canadian database team. We've also had a second meeting, and then we also met with the PIs of another study called OSLOT, which looks at outcome measures and tries to determine what the best outcome measures are to assess patients with esophageal atresia. And now, winter 2024 is today's presentation with me coming forward and sharing my work. So that's the most latest update on the project. Thank you, and any questions?
So I have well, there's actually other questions too, but I'll